Welcome to Optimized Health. How's everybody doing out there? I'm solo today. I don't have a co-host, so I don't have anyone to banter with for a few minutes. So I'm going to jump right into our guest today. This is a voice that is very familiar to us. She's been our guest in the past, and we are going to take a little bit different spin today on our topic. And I'm super excited to have Dr. Catherine Needham with us today. I'm going to let her tell you a little bit about her history. We've been friends and colleagues for a long time. I've learned a lot from her. She's been a huge part of helping us educate our staff and ourselves and how to work with our clients better and just provide better value. She also has a very unique business that she runs online or virtually. Mm-hmm. And so I'll go ahead and just, Catherine, tell us about your path, like kind of how you got to where you are now.
Sure. Thank you so much for having me. I've learned a lot from you as well. I am a pharmacist, and I graduated in 2013 and moved back to Chattanooga to join a compounding pharmacy where I spent 9 years focusing heavily on functional medicine, hormone balance. We did both sterile and non-sterile compounding, and a big portion of my day was spent managing hormone replacement therapy, and that was kind of the doorway into functional medicine for me. And so I met with women and men one-on-one to optimize their hormones, and about 3 years ago, I took a step back and then started working on the board certification and fellowship in functional metabolic medicine, anti-aging medicine. And then 2 years ago in August, so just this past August, I celebrated 2 years of Cycle Balance with Catherine Needham, where I, like you said, meet virtually with women one-on-one to optimize their fertility and their chances of conception so that they have a say in their fertility picture and meet that gap between thinking about trying to conceive all the way up to IVF and give them some control over that and really helping them conceive hopefully without IVF.
Right. And then tell me about your recent certification.
Oh, yes. I did
That's a pretty big deal.
I blew right by it.
Yeah.
I'm board certified in functional medicine. So I finished a fellowship. It's the acronym is fellowship. A fellow in anti-aging and metabolic medicine, board certification, same thing. And so it's basically treating the body as a functioning unit and trying in every way to get the body to work as it was designed to work instead of just masking symptoms, treating symptoms, or using kind of a sledgehammer approach. We're trying more to use a scalpel and really tease out what is at the root of each issue and really getting at that versus just treating the surface symptoms.
Mm-hmm. Well, that is beautifully said and rolls us right into our topic today. So we're going to talk specifically around polycystic ovarian syndrome, or PCOS. It's a hot topic in our clinic.
Hot topic.
We have women coming in all the time, young women of varied ages saying, I think I am. How do I know if I am? Could you check this? And so it really presents in so many different distinct ways that sometimes it's hard to wrap our brain around. First of all, how do we diagnose it? What are the treatments? How do we manage it? You know, where do we focus in our management? And so today, what I would hope from this episode is that we can give listeners a framework that they can learn, first of all, about the diagnosis, about the syndrome, and then take that to their provider and say, hey, can you check me for this? And then also do some things on their own to help improve their health situation.
Absolutely.
Yeah. So we'll just roll right into it. So polycystic ovarian syndrome, can you just tell us, like, how do we know the incidence is about 1 in 10 women is what I've recently read.
That's right.
Is that similar to what you've studied as well?
Yes.
So that's pretty,
a huge portion of the female population. And it's the number one cause of struggles with infertility, which I don't even like the word infertility. Fertility is a spectrum. It's not yes or no. It is the number one cause of contributing towards infertility or subfertility in a couple or in a female of the couple. And like you said, very, very common. And then infertility itself is very, very common. So a significant portion of women who are facing fertility struggles it's a result of something to do with ovulation. And that's
Right.
what PCOS in general represents, is that there is a less frequent ovulation. And whether in any individual woman, if that's more from higher androgens such as testosterone, DHEA sulfate, or more complex with insulin resistance and blood sugar regulation issues. The idea is that essentially what you see on paper is that the cycles are very long. From day one of period to the day one of next period can be highly variable, but in general, it's usually more than 35 days, but it can vary quite a bit there, even within one woman. So we have low frequency of ovulation and oftentimes higher androgens. And we, on ultrasound, as we were talking, sometimes we can see something called a string of pearls, because essentially the women will, their ovaries will have a lot of eggs that get to a certain point in development and then just kind of stop. And so they'll have something on ultrasound that looks like a ton of little circles. But in general, those are the types of things we see. The diagnostic criteria are not very specific.
Right.
So we don't, for example, the Rotterdam criteria is what's typically used, where you have to have 2 of the 3 criteria, including the ultrasound imaging, where it looks like a lot of tiny follicles, high androgens, but it doesn't even have to be high androgens on paper. It does not have to be a high lab level. It can be hirsutism, so like coarsening of the hair on your arms or on your lip, or thinning of the hair around the scalp, acne. Those can
be there without a elevated testosterone level.
That's right. That's right. And then typically there's, the very long cycles.
Okay.
Oftentimes what I see is that, especially now within the last 10 years or so, AMH has become a much more readily available lab. And that corresponds with PCOS, the higher it is, basically, because those tiny follicles, once they get to a certain point in development, they produce AMH. And so the more tiny follicles you have at that size, the more AMH is going to be produced. And that correlates really well with something called the LH to FSH ratio, which is another, it's a set of labs that we can draw on cycle day 3 and evaluate, is their body really struggling with ovulation? Is the body at the get-go, at the baseline, at the period, having difficulty recruiting one egg, fully developing that one egg towards ovulation? And that really is the crux of PCOS, is we have kind of, instead of some really synchronized hormonal cascades, it is not in the same way producing an egg cyclically in a really timed structure. And so we can see those labs, the AMH specifically, be elevated. Above about a 3.8 is about 80% specific or sensitive for a PCOS diagnosis, but again, not diagnostic in itself. LH to FSH ratio, not necessarily diagnostic, but it does correlate,
right.
Especially if it's above about 1.5, 2, and even 3. Those correlate quite heavily. And so I rely on those. I do
too. Yeah.
I look at them because they give you so many peeks into what's going on at the level of the ovary. In a more detailed way. I do look at testosterone free total SHBG, because sex hormone binding globulin, or SHBG, can be lowered, which means they have plenty of free testosterone. I look at DHEA sulfate, of course, and then on cycle day 3 specifically, that LH and FSH really give us a peek into what's going on. But where the rubber meets the road, where that cycle chart is, we got to see how long is it taking your body to develop that one egg that's going to be ovulated, because that essentially is dictating the cycle length.
Okay.
Post-ovulation, that is fixed just about your entire menstruating life. From ovulation to period, if that is 13 days, 1 month, it's probably going to be 13 days your entire life, just about. So what really is driving those shifts in cycle length have to do with the time it takes for your body to make that one egg that's going to be ovulated. And we can see in these labs how hard is your body having to work to do that, to get that one kind of swell of hormones with the hormonal oomph required to have ovulation. Is it having to work really hard? Are we seeing a really high LH to FSH ratio where your LH, instead of being about the same as your FSH, is 2 or 3 times higher? That really indicates that something is disrupting the process of ovulation all the way. We can see it all the way back at the period.
Okay. And so that something is the, I guess, cardinal question, right? So let's demystify it a little bit and just kind of bring it down to what are those root causes of PCOS?
Yeah, and there can be several. I like to look at PCOS and infertility on the whole as more of like a 3D object where we're trying to look at it from a lot of different angles and not just from the top.
That's a great explanation. Yeah.
And so we have to look at it with a lot of different labs because there's a lot of different factors. It's poorly understood. Again, the criteria for diagnosis are not super stringent or clear. It's not just strict cutoffs. So a lot of women have an underlying issue with blood sugar dysregulation, or what that means is their body tends to have higher blood sugar than somebody who looks just like them on paper, or their body doesn't quite produce enough insulin to keep up with the demand. And a lot of that has to do with just the American diet. It's
right.
It ain't great.
Yeah.
It ain't great. And so it's basically the harder your body is having to work to keep your blood sugar in check. That plays a big role in it because what we can see is that insulin resistance, meaning your insulin isn't working as well to get the blood sugar taken up into cells, that can directly impact your ovarian function. It can increase the amount of certain hormones that go into the ovary and increase testosterone production. But at the level of the ovary, it's not getting converted to estrogen. So you just get this buildup of testosterone with no shutoff valve. Testosterone in no way talks to the brain in the female body and says, hey, no more production. It just keeps cranking it out. That in turn results in dysfunctional ovulation. Like it's not quite, the hormones aren't coming together quite at the right time. And who would have thought, that blood sugar has anything to do with that, but they go hand in hand in these women. And some of it, of course, has a genetic factor, but if you think of PCOS or really anything that has an underlying issue of inflammation, which the inflammation is resulting in part from this blood sugar dysregulation, as a bucket. And if you put enough water in the bucket, it will overflow. Some women, their bucket, because of their genes, is maybe 80% full. They change very little in their lifestyle for the worse, and it overflows. And we're going to see those ramifications in their fertility and their ovulation. Some women are really lucky and they have like 20% full. So they could eat a lot of unhealthy foods or have different habits or environmental factors before their body, it overflows and has issues with insulin sensitivity and PCOS. But in general, it's about keeping that bucket less full from inflammation.
Yeah, that's a great visual, just because we hear inflammation. Sometimes it's hard to understand exactly what role that plays in the body. So let's talk a little bit about, okay, once you have that diagnosis, let's say, or you're suspicious for that, what are some ways, because I've seen your diagrams and I wish we had the visuals here to refer to because they're excellent. They help you to really...
They're on my Instagram.
Yeah, and I use them a lot. I say, let's look at her Instagram.
Yeah.
Let's look at her diagrams.
That's what it's there for.
Because, it really helps me to just explain to my patients all the different ways you can approach the management of PCOS.
Totally.
And I don't want to get too far ahead and skip over like the diagnosis, but there are so many different avenues you can go down to manage depending on how it's expressed in your body. Is that what you've seen as well?
Exactly. So if we have women, again, looking at it like from a 3D object, if we have somebody who is, it's more pronounced with that insulin resistance, which I typically look at a fasting insulin level, wanting that to be between 6 and 9. I look at a fasting blood sugar, really wanting that to be between 70 and 85 if at all possible. And then an A1C at least below 5.4. And so if I see any of those factors, because those three give us a peek at where on the continuum towards insulin resistance, like where in that severity are
Okay.
we? So look at those three things. And if those are the most pronounced symptoms, then I really like to use inositol because it helps the body kind of get these little receptors up to the top of the cell so that blood sugar can get in. And oftentimes I couple that with CoQ10 just for antioxidant support. But certainly if we have a more like high androgen picture, again, we have to we have to underpin all of it with blood sugar regulation. But if she's not trying to conceive, certainly, do you guys ever use like semaglutide? Or
Oh, absolutely. Yes, the GLP-1s. Yes,
just
absolutely.
to help with that insulin sensitivity part of the picture. And then spironolactone is a great prescription medication that can be used. It can take about 6 months for full effect, but it can really help with those pronounced physical signs and symptoms that can be more bothersome on a day-to-day basis. It's not going to help with cycle regularity, but acne, hirsutism, it can be really helpful. And so aside from the blood sugar management, so we have inositol, the tides, as you will.
That's right.
And then metformin can sometimes be used. It can cause enough stomach upset that some women are like, I'm not into that.
Doing it. Yeah.
But I do like that it can be used with inositol. A lot of antioxidants that basically are good for cardiovascular health.
Right.
Because they're working at the level of the cells to clear out inflammation and oxidative stress. Well, the ovary is a very busy little bee. And it's going to get a lot of that oxidative stress before you might see it other places. So, fish oil, high quality omega-3. I really like N-acetylcysteine, CoQ10, like I said. Those are probably my heavy hitters.
And that's more for the insulin resistance piece or the blood sugar dysregulation, correct? Or the inflammatory response around the ovary due to that, correct? Okay. And then when women are, what I see so many times is women are they come in just really frustrated, because it's like they've read this or that or been told this or that or not had a diagnosis. So when we're trying to understand, there's like a list of 30 supplements sometimes.
For sure.
Could possibly be effective for PCOS. Inositol seems to be my number one.
Like you can only do one.
If you can do one,
you can spend your dollars one way.
Yes.
That is how I would spend it.
And then NAC.
I do. I love that. CoQ10 is a heavy hitter in its efficacy. It is a more expensive supplement just in general.
Okay.
Across brands, it is one of the higher cost ones. There are products that combine inositol and CoQ10, like Thorne does that, and I like that one a lot. I do love that one. It also has a pomegranate extract, which can help with dysfunctional HDL. That's another day.
Another podcast.
So I like that product on the whole. But to your point, yes. I mean, curcumin, berberine. Vitamin D. I didn't even talk about vitamin D. Got to optimize that vitamin D. But yes, there is quite a lengthy list. But if I can only pick one, I'm picking probably inositol.
Okay.
If I can do a couple, I would probably add on CoQ10, N-acetylcysteine. Sometimes I leave off vitamin D when I'm listing things because I like to dose that based on a lab value.
Sure.
And it's not something that I can just say, go get it and take this dose for everybody, because that one has to be personalized to the level versus inositol, CoQ10. Like those can be started.
Right. What target are you shooting for your vitamin D?
I mean, if I could just pick any, 50 to 70, even up to 80.
As well.
But labs will report normal, as you know, at just above 30. Well, that's just a sad little level.
That's just optimal. I mean, that's right at the very low end of being optimal. We want we shoot for 50 to 60 as well. So as far as supplements, inositol, CoQ10, NAC, vitamin D. And then perhaps even like you mentioned, the spironolactone or a prescription. How do you use progesterone?
Oh, I do love progesterone.
Yeah, that's one of my favorites.
Yeah. Yes. What I love about progesterone is because PCOS is a lot of intertwined cycles that are kind of feeding forward and making each of them worse as they progress. Any of these things that we've talked about even so far can kind of provide a shock to any one of those angles, and progesterone being one of those, because progesterone is a hormone that is only made in the body in any appreciable amount in response to ovulation, because it is only produced by the part of the follicle that hangs out in the ovary after ovulation. The little egg goes out, The corpus luteum is what is produced, or is what hangs out in the ovary and produces the progesterone. So we only have that after ovulation. Well, if you don't ovulate, but say every 45 days, your body is at a relative deficiency in its exposure to progesterone, because the body is made, the female body is made to work in kind of a call and response. You have an estrogen dominant wave, and then it's supposed to be a pretty equal progesterone wave as far as the number of days that progesterone is in charge. So that call and response. But again, if you don't ovulate till cycle day 32, and then you have a phase that's dominated by progesterone called that luteal phase, is only 12 or 13 days, well, then your body is heavily favoring that estrogen dominant phase. And that in turn, in the next cycle, can delay ovulation. So because of that kind of rollover, I really like to use progesterone when we see these longer cycles, but it has to be used at the right time. You cannot just start progesterone any old day.
Yeah.
It has to be timed with when the body would be making it otherwise, which is after ovulation. So once I confirm with the client that she's ovulated based on cervical mucus patterns, we use it for 10 nights.
Okay.
And I started on peak +4, meaning that for the night of the 4th day after peak fertility. So if we identify the day of peak fertility as cycle day 20, then I'm going to start progesterone the evening of cycle day 24, because the last thing I want to do is have progesterone come in too early and interrupt the cascades around ovulation. But then we use that for 10 nights and then discontinue it, which will either trigger a period if conception didn't occur, or it means we need to go run to get some labs if perhaps
it did.
perhaps it did. Woohoo! But we'll do that cyclically in that way, only using it during that part of the cycle. And it can take a few cycles, but that should in general slow that rollover so that they hopefully start ovulating earlier in the cycle. That's kind of the simpler way of looking at it, is that kind of rollover way. But what happens is progesterone starts acting or doesn't have the amount of time to act on the like gonadotropin releasing parts of the brain and get it kind of primed in just the right way if you don't have regular ovulations.
So what if someone is not ovulating regularly? How do you typically like to use progesterone then?
I still use it once I do identify ovulation, because almost without exception, I can think of some ways that I might need to use it to trigger a period. But generally speaking, even if I have a woman who has long cycles, she does eventually ovulate. And so often what I do is wait for that ovulation, as frustrating as it can be when you're just waiting and waiting and waiting and waiting, waiting for cycle day 40 or 45 to appear. But I want to match her body's rhythm and kind of get in a groove with it.
And that's why you're hearing Catherine talk about, that's exactly what you do in your virtual sessions, right? You're going through these charts with women, talking about their cervical mucus, their
LH searches, but sometimes basal body temperature, but not necessarily. I look at their labs, but we're meeting frequently enough that I haven't just said like, go cycle chart for 3 months and figure out when to start progesterone. It's like it's a high touch point type practice where I have the ability to be like, all right, here we are.
And you're working with women not only who are trying to conceive, but maybe just trying to get their PCOS managed. Correct?
Yes. I have quite a few clients who are in their early 20s who have seen what PCOS can do in their late 20s when they want to conceive. And so they're trying to get ahead of that now and aren't necessarily wanting to just do contraception. Like they may not need the contraception itself, like they would only be using it for cycle regulation. And so they want to handle it that way, handle it more on a functional medicine basis than starting a contraception. But yeah, it's a lot of women who are not necessarily trying to conceive imminently.
Right.
Or like housekeeping. Like I'd like to have a baby and I want it to be easy when I do.
Yes. And then I think, young women are realizing how they can educate themselves and take control and manage some of these symptoms like the hirsutism, the acne, the weight gain. And they correlate their periods. And so they're wanting and looking for ways. I have women reaching out to me that are, friends of friends of friends,
Yeah.
because they just want someone to look and listen and give them some ideas that they can start working on now.
Absolutely.
To prepare their bodies for the future.
Yes. Yeah. And to not feel like your body is the enemy.
Right.
To not feel like your body is somehow defective. And then because that can really start some self-hate.
Yes.
Like,
Negative self-talk.
And
Yeah.
we just don't need that.
Nope, we don't.
Not if we can avoid it. And so getting those resources, and a lot of it really, like you said, it just comes down to listening to their individual concerns and taking more than 3 or 4 minutes to assess them. I honestly don't even like tossing out the word PCOS with a client because I know they can go Google it and see all sorts of terrible things that can occur with their fertility or their hair growth pattern or acne or weight gain. And so I honestly don't even throw that out necessarily because the term itself doesn't dictate how we treat the patient.
Right.
The patient, well, first of all, the patient's signs, symptoms, labs, and their preferences come into play. And I look at, again, from all angles. I'm always hesitant to just throw out even the word PCOS because it's not clear enough to use just in a blanket way. It has so many strings attached to that phrase that I really am more focused on. Okay, well, you tend to be somebody who ovulates less frequently and you have high androgens. So let's look at that. Or let's optimize your blood sugar regulation instead of just being like, well, you have PCOS, because that's what is helpful is the tools.
Right.
Not necessarily the nomenclature if the nomenclature and diagnostic criteria get so perfectly squeaky clean and easy for us to assess who has it and who doesn't, then sure, maybe.
Right.
But that's the whole point of having a clear diagnosis is so you have a clear treatment plan.
Yes, absolutely.
And PCOS is not that.
No, it's not. And it's, I don't know what you see, but most of the time women are dealing with this on into their, menopausal years because some of that doesn't really, stop. We still see problems with insulin resistance as we lose progesterone in perimenopause. And so some of those supplements even we recommend for like perimenopausal women because some of those root issues are you have, it's a little bit different, but less estrogen, more insulin resistance, less progesterone. So as far as let's keep going with PCOS though. I don't want to get us too off track, but so we've talked about the supplements and the progesterone, some other prescriptions like spironolactone. What do we think in terms of like lifestyle? So let's talk a little bit about the diet, movement or exercise, and sleep and stress. Those 4 things that are just like the pillars of hormone health for all of us.
Yes.
What are some practical ways that people who have more PCOS-like features can really target, what types of exercise, what types of diets work, that sort of thing?
Certainly. And none of, like you said, these are the lifestyle pillars kind of across the board. Like these are not like super sexy things that sound like you've never heard before. But principal among them, of course, is I think circadian rhythm and making sure that you also align your circadian rhythm with your eating. And so having a really good sleep routine, shutting the lights off. We call them the big lights at our house. You know what I mean? Like we can have the little lights on after about 6 or 7 p.m., but no big lights because that can interrupt melatonin production in the brain just by having light, because we have light sensors is some of the most primitive parts of our brain, and like the clocks within our body are very primitive and they run based on light and you can't trick your body's clock. You just can't do it. So really matching that with when you sleep. Hopefully, if you can get off night shift, that would really help your fertility. And that's just not doing anybody's fertility.
Night shift was not fun.
It's not great.
I have been there, done that.
It flattens the cortisol curve, lowers it. It is not great for the body because you can't trick it. And then aligning that sleep routine then with your fasting for the day. So trying to have 13, maybe even 16 hours of fasting. Okay. Just to align what our bodies were meant to do back when we lived on the Serengeti. Yes, we were eating berries all day. We did not eat at 10 p.m.
No.
We did not wake up and have sugary beverages,
cereal
at the get-go.
Yeah.
Exactly. And
Starbucks.
So we would fast basically when it was dark, more or less. And so matching those two things, with the circadian, so your sleep and your eating pattern with circadian rhythm. And there is a ton of data to say how that influences your insulin resistance. And it is playing the long game. Like if you start your sleep hygiene and circadian rhythm, like matched eating today, you're not going to ovulate tomorrow necessarily.
Right.
But in 2 or 3 months, it is going to make a difference. And it's going to make a difference for you now when you're 50. Like if you're 50, you're going to wish you had done it.
Right.
And so sleep, it is your job. Sleep is anti-inflammatory.
Right.
You got to prioritize it.
I've heard that. I think I can't remember who it was. Huberman maybe have said that, sleep like it's your job.
It is.
Because that is so instrumental to how we approach life in every aspect. And then also our body's physiologic response in terms of insulin resistance.
Yes.
So
huge impact on insulin resistance. And again, if you think back to a circadian rhythm, and those light dark receptors, and basically like how many times does the body perceive light to align with a menstrual cycle? Like we can't beat those primitive parts of our brain. So certainly circadian rhythm, but with sleep, your brain is a dumpster, and all day long it's picking up trash. You got to dump it out.
Yeah.
So circadian rhythm, I do like exercise. I tailor it to the woman's kind of physical, in their appearance. And what I mean by that is, like, if I have somebody who is clearly like a long distance runner, well, we need to do something different than if somebody is kind of more that classic PCOS with maybe more like central weight gain, because that person, I might need to start with just 10 minutes of walking a couple times a day. So if I can get her doing 10 minutes of walking a few times a day, well, that's going to equal that 150-minute goal for the week pretty quickly. And so she's going to go from somebody who didn't exercise at all to somebody who's now walking at least the recommended amount within just a few days. And so I often start there.
Okay.
If I have somebody who's more high intensity athlete, it's more about switching their focus to something like yoga, walking. Basically, if I have somebody trying to conceive actively, I'm trying to avoid like HIIT, CrossFit, distance running.
Is it too much stress on their body, like increases cortisol?
Yeah. It can really impact ovulation. So we just kind of shift gears, or if they wear like an Oura ring or something, heart rate monitoring, they can make sure that their exercise is keeping them within kind of the BPMs that we might look for. So certain kind of finding the happy medium with those, with exercise, depending on the characteristics. And then for diet, I really prioritize fiber, because estrogen, as we talked about earlier, you can be estrogen dominant. Well, that estrogen has to get out somehow. And the body loves to recycle, so it will just pick it up from the gut if it can. Versus creating new. So then you can really accumulate estrogen even. So I have them prioritize fiber, about 25 grams in there per day of fiber to help that estrogen breakdown and removal. And if you're doing that, you probably are not going to be able to prioritize unhealthy foods.
Right.
Because if you're shooting for a goal with that much fiber, it has to come from fruits, vegetables, grains. Like you have to have higher quality food to make that goal. And so if you look at that piece, the rest is going to fall into place.
What about protein?
I don't put strict limits on it, because typically a lot of the diet, that part tends to be
work itself out.
It does.
Yeah.
If they, and I know not everybody likes the food
plate
pyramid,
the plate,
but I love the
method.
plate.
Yeah,
yes,
the plate method works.
It just works. And if you think of how big relative to another serving of something else is, like, that makes a big difference in that mental picture. And so I like the plate.
Yeah, there's actually an app where you can take a picture of your plate and it'll tell you if it's maybe it's called Plated or something like that.
Cute.
Yeah, so there's a lot of neat ways that you can like help yourself if you need that to kind of organize your meals better. And I
always provide a list of higher fiber, plant-based proteins, things that are going to give them both protein but steadier blood sugar, higher fiber, and then I always include information about the modified Mediterranean diet. It just has
Mediterranean
so much,
is like the number one. If you read about anything, it's like Mediterranean.
Yes.
Yeah,
and there are some good recipes out there, plenty of resources, because it is so well studied. It is not a fad. It's nothing that is so out of the ordinary that it's not sustainable. And to me, you can have the best supplement the best anything. But if it's not sustainable, if you can't afford it, it takes too much of your time, too much effort. It doesn't.
It's not going to work.
It's not going to work.
Yeah.
The pills don't work in the bottle, and so it has to be something you're going to be able to sustain. And so I focus heavily on fiber because it's kind of a yes/no question. You can flip it on the label and see.
Yeah, and that's why with my patients, I do like to give them a short list of supplements because that 30 supplement long is so overwhelming.
For sure.
So so let's just review a little bit, and then I want to get some action points moving forward. So PCOS, Polycystic Ovarian Syndrome, 1 in 10 women have it. You might have increased androgen symptoms like acne, abnormal hair growth. You might see more mid-abdominal weight gain, definitely irregular periods or longer cycles. So it doesn't have to be that irregular period term, but your cycles will last longer. You might see on ultrasound the little follicles around the edges of the ovaries if an ultrasound was done. Am I missing anything on that symptoms wise?
That pretty well
maybe
covers it,
maybe difficulty conceiving. If you're trying to conceive, you may see that.
It's just so hard to predict a fertile window when you have cycles that are, even if your cycles are very, like you said, rock steady, but they're just really long, it gets a little, you don't have as many chances per calendar year as somebody who has, say, 26 or 28 day cycles. But especially if the cycles are irregular in length, well, you can't predict when your fertile window is going to be to say, okay, no, I can go on that work trip. It's under my fertile window. Like it just makes it a lot harder to pin down.
Plan that out. Okay, so we talked about the diagnosis. Now, treatment-wise, supplements, we're going to look at inositol first.
Yes.
CoQ10.
CoQ10 and NAC. And then
NAC.
Because so many of my clients are trying to conceive, say, in the next few years even, I do an omega and or they're on a prenatal, and so prenatal with prenatal DHA. And so I kind of skip that one in my main list, but that's because it's kind of included with the prenatal idea. But an omega.
What about magnesium? Do you? Yeah,
I like. I mean, so, if you like, if that's.
I know they're all good. They're all good. I'm just trying to simplify it.
Absolutely, but I like magnesium on the whole because of all the functions it has in the body, but also again part of that gut regularity. If the body can recycle from the gut, it's going to. So I do like magnesium, and for your healthcare spending dollar, magnesium is an economical supplement. NAC is an economical supplement. CoQ10 again, if like I have to conserve the money, if I have to conserve on the money, I might prioritize something over CoQ10. But if money is no issue, it's going to be in the top. Inositol, not super expensive.
No.
Vitamin D is not super expensive. But usually what I'll do is like, if I can only do one thing today with you, this is what I would do. Or if we can only spend $2 per day on supplements, I would do these.
Okay.
And then kind of move bigger picture from there.
Okay. Yeah. Add to it from there. And then prescriptions, perhaps progesterone, perhaps metformin, perhaps spironolactone. So there are some prescription options if needed. And then lifestyle piece, sleep, stress, exercise, diet. So am I missing anything when you think about management, when we think about like that total picture?
I think the only aspect of management that would clarify the picture even is cycle charting with some sort of data, like evidence-based
ovulation
method. Yes, we got to track that ovulation. And I tend to use, I rely heavily on cervical mucus patterns. If we use LH surge monitoring, or OPKs as they're sometimes called, or basal body temp, it's an adjunct really to if we're having trouble deciding between a couple days which day ovulation has occurred. Well, then those things might come into play. But I rely heavily on cervical mucus monitoring because it is basically like a daily lab value.
Right.
There's Mira, there's Anita, where we can look at these urine metabolites, but where the rubber meets the road and where what your body is doing is mirrored in cervical mucus. It's either controlled by estrogen or it's controlled by progesterone. And we can see that and basically get a day-by-day picture of what your body is doing without expensive, tools and apps.
Right.
And the other thing about that is we can look at certain things tend to happen in women with PCOS on their cycle charts, not just from day one, a period to day one being longer, but they will tend to have like patches throughout, like several groups of several days throughout their menstrual cycle where they'll have fertile appearing cervical mucus. And that can make it really, really hard when you're trying to conceive to nail down where ovulation is occurring. And so one of the things we can do is, are you somebody who has that on your cycle chart? And as we move forward, does that become less and less prevalent? And so cycle charting is almost diagnostic in the way I use it.
It is, yeah.
And it's monitoring and in a lot of ways. And so because it is so heavily how I monitor, then I treat it like I would any other type of management.
And it's free. Like,
it's free.
Other than, your services, but free. I mean, right.
It's a life skill.
Right.
You meet with me a few times and for the rest of your life.
Take it on for the rest of your life. Yeah. So then what are typical expectations? Because I always we see our patients and then we may start them on a certain regimen and we see them back in 6 weeks and then we see them every 3 months. We're checking labs, meeting with them. But sometimes I think the expectation is that it's going to happen a lot sooner than it does. And I often say, we really have to hit this intensely from all different angles or we won't get control of it. We won't get, proper management of it. But what would you say is a proper time frame if you're hitting all those things that we've discussed, supplements, meds, lifestyle piece? What would be the time frame that you would say, you should start seeing some results?
Generally in a few months. I meet with them every 2 weeks initially. Okay. It kind of depends on where especially the initial appointment falls, so that we can identify when we best need to meet. Again, I try to align appointments with ovulation and then either their period or sometime right around the end of the cycle or beginning of the next. And so usually the first appointment is heavy on education and their health history, making sure that I'm up to speed. And then at the second appointment, if we can line up when labs would best be drawn, that's a great point to do that for us and see when cycle day 3 labs could be drawn. And then we're always looking forward and back and seeing, like playing a little bit of Monday morning quarterback when we're looking at their previous luteal phase. Was it sufficient in length? Did we identify the fertile window appropriately? And then looking forward based on those trends, what we might see in the next cycle. Cyclical progesterone, I typically anticipate a 3-month time frame for it to start changing cycle length. Blood sugar is another one that I tend to think is going to be a little bit kind of more the long game, but nothing that is worthwhile for your long-term health changes tomorrow. Right. Not a single thing. Right. And there is not a medication that you can take today that means tomorrow you're a healthier person. You have to play the long game, and fertility is a peek into that long game. Your fertility is a peek at your overall health. And so we have to look at those things that are overall best treating your body as a whole, because your fertility is just one piece of it. And if something right there, it means something ain't right.
Well, and when we think about PCOS long term,
cardiovascular risk,
we're looking at, increased visceral fat, possible increased risk for diabetes, all the cardiovascular markers that are associated with insulin resistance. And so even there are some mood disorders associated and some increased cancer risk with visceral fat accumulation. So managing PCOS is more than just our younger years. It's our long-term health.
It is.
And so I think sometimes it's hard to wrap our brains around that when we're young and vibrant. Yeah. And we're just trying to,
we're just trying to live our lives.
Yeah, exactly.
Just trying to get pregnant.
But, long-term, you can have some really serious complications if that doesn't get under control.
If it never gets at least discussed with you. And we do our women a disservice if we don't. And I am so happy that now, 10 years after I faced infertility, it's part of the discussion, not just with me. I mean, but now it's part of the discussion we have about yes, this is helping your fertility now. But it's also improving your long-term health,
your cardiometabolic health.
Absolutely. Yeah. And that is so important. Like when I felt I was facing possible PCOS, but not the typical type. And so where did I fall with? And I wanted to know more about what does this mean for my long-term chance of diabetes? And it was just nobody knows.
Nope. Yeah.
Or even if it had been studied, it just wasn't part of the routine conversation. Whereas when I meet with women, that's one of the first things we talk about is insulin resistance. Right. With regards to ovulation timing. one of the first things out the gate. And I don't think I'm unique in that. I think that is the medical community has come that way. And I'm really, really happy for what that means for women's long-term health.
Yes, absolutely.
And men's, honestly, because they're analogous organs. And so if the wife gets started on those and the husband they can live long, happy, cardiovascular disease-free lives.
Well, there you have it, folks. Well, this has been wonderful, enlightening as always, and you just help us understand it in such clear, practical ways. So thank you for that.
Yeah.
Tell our listeners how they can find you, where they can go to get to you.
Yeah, absolutely. My handle on TikTok and Instagram is at CycleBalanceDoc. I also have a YouTube channel with some kind of longer bits of information, but I'm pretty active on Instagram and TikTok, and I really try to hit what makes a difference in your fertility as soon as we can with like the best bang for your buck is what we're about, like nitty gritty.
She's down to business.
I'm down to business. Yeah. And so I'm active on social media. I obviously have a website as well with some more information. But then evenings and weekends, you can find me on my laptop.
I know. She is such an excellent source of information. So thank you, Catherine, for being with us today. And until next time.